Alright, so chapter 6, lower limb positioning. Definitely use these slides for labeling so you know what each one of these are. We've gone over these in the past video and past slide. So you have the answers for all of these. And I just want to use this as a review for you to use them as labeling. We've got everything from the foot to the ankle, the lower leg. We've got the knee, and once again the knee as well. So, and the patella. So use those as labeling. Like I said, that's going to help you with your critique exam. So we're going to start with technical and positioning considerations. So 40 inches, gonadal shields for sure, gonadal shielding. So make sure that you place a lead apron on them somehow. Always four-sided collimation. Your correct part, your CR alignment part is parallel to the image receptor. Your central ray is perpendicular to the part and the IR, unless of course you're using an angle, and then make sure that you have the proper angle and that angle is centered to that image receptor. Always the proper anatomic side marker, so make sure if it's the right side, the right marker, left side, left marker. Your KV range is going to be 50 to 70. It's a short exposure time. You're going to be using that small focal spot. Adequate mass, and then grids for anatomy that measure over 10 centimeters. So make sure that you measure, know where to measure. Patient history. Always do patient history. Make sure that you get a good patient history. So, why are you here today? Are you having pain? Where is the pain? How long have you been having it? Does it radiate to somewhere else? Use the 1 to 10 scale. 10 being the worst. What is your pain? Is it a 6? Is it a 7? A 5? Can I touch here? Can I touch there? So you don't just injure the patient more. How did this injury happen? When did it happen? Is there swelling, redness? Do you notice dislocation, bruising, or is there a laceration? Ask them all those important questions. Ask history, previous surgeries. If you have, what kind of surgery was it? Where was it? When did you have it? If no injury, you always ask, is it possible disease, osteoarthritis, osteoporosis, cancer, etc. And then in female patients of childbearing age, always an LMP, but you're always going to shield as well. So it's not as relevant as if you were doing an abdomen or a pelvic exam. So always ask LMP, when was the first day of your last menstrual cycle? Preparation for the patient, always remove the artifacts. Roll the pant legs up or take the pants off, depending on what you're doing. Remove the shoes, remove the socks, jewelry, toe rings, anything like that. And then bandages, if at all possible, try to remove those as well. If you can't remove the bandages, just note in the exam that you were unable to remove the bandages. Exam may be performed on the x-ray table, in a seated position for the patient or in a supine position for the patient, whatever's easiest for them. And then you can also perform these images in a bed, in a stretcher, in a wheelchair, if necessary. So you can see here, this one's being done in a wheelchair. So instead of moving the patient from the wheelchair to the table, they just brought an extra chair over, and they're going to image the AP ankle, the lateral ankle. You can do an oblique ankle there as well. You just want to make it as comfortable for the patient as possible and easy for you, whatever's easy for them and for yourself. So we're going to start with AP toes, so the digits of the toes. So central ray is 10 to 15 degrees posterior. So anterior and then posterior. So we're not talking caudate or cephalad. So anterior, posterior. So 10 to 15 degrees toward the calcaneus. So your calcaneus, and it's to the MTP joint. So the metatarsal tarsal joint. CR should be perpendicular to the phalanges, and then on an 8x10 image receptor. Collimation, don't forget your marker, and this one, make sure the marker is correct. So instead of upside down like this, make sure it's flipped. But you're to the metatarsal phalange joint. So you can also do, if you're doing digits, so this is an AP second digit, you can use a 15-degree wedge, which they have here, and then you're not using the angle. So you only use the angle if you're not using a wedge. So if you're flat to that image receptor, then you need that angle. So this one, they've limited the angle or taken the angle out due to the fact that they've put that positioning sponge in and created that 15-degree wedge. So now your central ray is at 0 degrees to that MTP joint. So your evaluation criteria for your AP toes, most important here, don't collimate off your marker. Make sure that your marker is in there, and if you have to open your collimation a little bit wider to include that marker, that's okay. Usually that way you'll get a toe on either side of the injured toe. So digits and minimum of a half of the metatarsal. So minimum of half, they have almost the entire metatarsal, which is not wrong because it's at least a minimum of a half. So no overlap of soft tissue, so you don't want toe over toe. You don't want this big toe protruding into this image here of soft tissue. You want to make sure that there's good separation. Interphalangeal and metatarsal phalangeal joints appear open, so you can see the open joints throughout the toes. Shafts of phalanges should have equal concavity on both sides, so you've got the concavity here and here. So this is a true AP position, and it's not rotated. Optimal exposure factors. So AP oblique for the toes. Central ray is perpendicular. So perpendicular, so you're rotating the toe to that oblique 45. So you don't need that 10 to 15 degree angle anymore. It's a perpendicular 0 degree to the MTP joint. You're obliquing the foot 30 to 45 degrees. So medial rotation for 1 to 3. So 1, 2, 3, and then lateral rotation for digits 4 and 5, 4 and 5. So it gets them closer to the image receptor because you can see here that they're moving away from the image receptor. You're going to get magnification. This puts them closer. So digits 4 through 5, a lateral rotation, medial rotation for 1 to 3. You can see here that they use tape to pull the toes out of the way to image that big toe all by itself. Keep in mind you may have to do that for individual toes just to move it to a lateral position to be able to view it by itself separated from the other toes. So your evaluation criteria for your oblique toes, once again, don't collimate off that marker. Make sure that you leave that collimation open enough to get that marker in there. So half of the metatarsal, so they have at least half, they have almost the entire thing. The IP and MTP joints appear open, which they do. You can see them here, open and open, especially in the affected toe. Increased concavity on one side of the shaft, so you're seeing the concave here, and this is becoming more straight. Concave here, becoming more straight. So that's what you're looking for. And then heads of metatarsals are not overlapped. So your metatarsals here, the heads are not overlapped. You don't have too much rotation where they're starting to lay over top of one another. And then optimal exposure factors. So if they're laying over top of one another, if they start laying over more, then you're too lateral. So more overlap means it's more lateral. Less overlap means it's more AP. Okay? So the straighter this line here becomes, the more AP it looks. The more concave this line looks, the more... I think I said that wrong. The straighter this line appears, the more lateral it's becoming. The more concave both of these become, the more anterior that foot is positioned. So your lateral first digit, lateral medial, so lateral side to medial side, it gets it closest to that image receptor. Central ray to the interphalangeal joint. So we know that on the big toe we only have the interphalangeal joint. The other toes we have the distal interphalange and the proximal interphalange. But the big toe is just the IP joint. So you're coming down to that IP joint. That toe is right on the image receptor, and then you're moving the other toes out of the way, either with tape or some other way to image just the lateral toe by itself. So medial lateral, you can see here that they've used a roll of gauze and then tape to separate that little toe by itself. So medial to lateral puts the little toe by itself to the pip joint, include your marker, and separate those toes. So evaluation criteria of the lateral toes. Once again, make sure that you include your marker. You're seeing this little toe all by itself. Usually the distal and the intermediate phalange is what you're going to image. Your proximal is going to kind of be overlaid by some of the other toes, but this is a really good lateral. So digits presented in a true lateral position, and you can see it's in a true lateral. The IP and MTP joints appear to be open, and you can see the open joints there and here. Digits are free of superimposition, and this is as free of superimposition as possible because it's really hard to separate them this close to your metatarsals. So optimal exposure factors. Your sesamoid bones, which are not done very often, but when they are done, there is the supine-Hawley method. So your sesamoid bones are up here, so you're going to have magnification. Prone, the Lewis method, they're closer to the image receptor, so it's decreased magnification. That's kind of the separation of both of those images. Once again, you're just going to see what your patient can do. Can they lay prone? Can they do this with their foot? Can they lay supine? Is this going to be easier for them? So, special projection, sesamoid bones. Also keep in mind it's tangential because it's skimming that body part. So remember what tangential is. It means skimming. We're skimming that body part, imaging those two sesamoid bones. You need to dorsiflex the foot. So you're pulling the toes away. So the plantar surface forms a 15 to 20 degree angle from vertical. So you want that 15 to 20 degree angle from vertical. Says which one is preferred and why. The one that is preferred is the prone because it reduces magnification, but it just depends on which is easier for your patient. So preferred is the prone Lewis method. Doesn't always mean that it's going to be the one that you actually do. Evaluation criteria of the tangential sesamoids. You need the sesamoids free of superimposition. So you want to see the joint spaces open, which they are, and then minimum of 3 metatarsals seen. So 1, 2, and 3 metatarsals. You may have more because you don't want to clip your marker off. So keep that in mind as well. And then optimal exposure factors. You're seeing the grays. You're seeing the sesamoid bones. They're not burnt out, and they're not. They didn't overly absorb the X-rays. So your foot routine. Routine's going to be an AP, oblique, and a lateral, and then there's special images, which are the AP and lateral weight bearing. So keep in mind you may use a 10 by 12 or 11 by 14. It's all dependent on the size of the foot. You may even need to use, say, 14 by 17, somebody with extremely large feet. You're going to use an angle here, and that's because your toes are coming up at an angle, and if you were to come 0 degree, you're going to close all of those joint spaces. So this angle is to ensure that those joint spaces are open when you create that image. So your AP foot, your central ray is angled 10 degrees posteriorly. So once again, we're talking posterior and anterior, not caudate or cephalad. So perpendicular to the metatarsals. So 10 degrees to the metatarsals, and then you're centering at the third metatarsal. So the third metatarsal right there is your central ray. Your evaluation criteria of your AP foot, you need the entire foot visualized, which you want to pick up that calcaneus back here, and then all of your toes and all of your soft tissue. Don't clip that soft tissue. No rotation of metatarsals, so all your metatarsals are free of superimposition. They're not in an oblique position, they're in that AP position. MTP joints are usually open, so metatarsal phalangeal joints. Nearly equal distance between 2 and 5. And then separation at bases of 1 and 2, right there. Slight overlap, base of 5, 2 to 5. So you're getting overlap and overlap here. So open intertarsal space. So you can see your tarsals, your open tarsal spaces. This is a really good AP foot. And then optimal exposure factors. Your AP foot, you're going to note slight differences in the TMT joints, tarsal metatarsal. So this is CR is perpendicular, no angle. So this is a 0 degree, okay? And then this is with that 10 degree angle. So you're not seeing your open joint spaces here very well. You're seeing great open joint spaces here, 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 through here, when these are now closed, okay? So that's the difference between a 0 degree and a 10 degree. That's why you need that 10 degree to make sure that you see those open joint spaces. A compensating filter, which you'll probably talk about with Mr. Garza, they don't use compensating filters at the clinic sites, but understand your compensating filters, what they do and how they do. So you note how the tarsal bones are better visualized. So this is better visualized. So what's happening is you have a compensating filter, say that's wedged like this, okay? So this is the toe side and this is the heel side, okay? So this is going to absorb more x-rays on the toe side because it's thinner. So your thinner part, your toes go here, and then your foot, your heel goes here, and then your central ray down. So then you get equal penetration through that entire foot. So you get really good toes, really good metatarsals, tarsals, and the joint spaces because of the penetration and the compensating filter that's been used. So your AP oblique foot is a 30 to 40 degree medial rotation, okay? So to the midline, 30 to 40 degrees, and then your central ray is still at the base of that third metatarsal joint right there. So your evaluation criteria of that medial oblique, the entire foot. So once again, don't clip your soft tissue of your big toe. Make sure you include the entire calcaneus on that foot. Your third through fifth metatarsals are free of superimposition now. So you have free of superimposition, and then tuberosity demonstrated at base of fifth metatarsal. This is very well demonstrated there. Your cuboid is open on all four sides. 1, 2, 3, 4 on that cuboid. Your sinus tarsi is seen very well right there. And then optimal exposure factors. All your shades of gray throughout the entire foot. Your alternate lateral oblique. So the lateral oblique, make sure you don't clip off the toe, the soft tissue. 30 degree lateral rotation. So your medial rotation, as we talked here, is 30 to 40 on a medial, and your lateral is a 30. So 30 degrees on that lateral rotation. CR is still at the base of the third MT joint and demonstrates the base of the first MT and medial metatarsals. So the base of the first MT and then your medial tarsals right here. So your medial cuneiform, your navicular, those are better visualized in that alternate lateral oblique. Your medial lateral foot, so most images of your lateral foot is going to be medial lateral. It's not wrong to do a lateral medial. It just depends on what the patient's able to do. And this seems to be the most often used, the medial lateral. It's the easiest for the patient to position. So make sure they're in a true lateral. The plantar surface is perpendicular to the image receptor. Your central ray is to the mid-cuneiform base of the third MT joint. So still where that base of the third MT joint or the mid-cuneiform. And then you're going to dorsiflex the foot. So dorsiflex the foot. Make sure that it's not pointed down. Your toes aren't curled under. Make sure it's in that true lateral position. So don't curl the toes, don't clip the toes. right here, it's looking like you could clip that big toe there. This is not a true lateral. You can see that it's starting to kind of curl under here. So make sure it's in a true lateral position. True lateral, true lateral, true lateral. Gets the foot into a true lateral easier, but is less comfortable on that lateral medial. So it gets it into a true lateral, but it's harder for a patient to do it. That's why we do the medial lateral. So still to the mid cuneiform and the base of the third MT joint. And then your evaluation criteria of your lateral foot. You want the entire foot visualized, so soft tissue of the toes. You want soft tissue around the calcaneus. The tibulatalar joint right here is open. You're going to demonstrate at least posterior half of tibia. So posterior half of tibia right here. You can see the two bones. So it should be in the posterior half. The distal metatarsals are superimposed. So you have your phalanges superimposed as much as possible. The distal metatarsals here should be superimposed as much as possible. And then optimal exposure factors. You don't want your metatarsals in a stair-step pattern through the entire image. That's showing rotation. So you want them overlaid, superimposed as much as possible. AP foot, lateral foot. So this is just showing that if they're not able to bend their knee 90 degrees and put the foot flat on the board, you can do this. You're just compensating by angling the image receptor. You're going to match the tube to the image receptor because the foot is already at an angle. So this is just like using that positioning wedge on the foot. And your lateral foot is a lateral to medial, and this is usually done if you're doing it, say somebody in a wheelchair, somebody in a stretcher, because it's easier to do this instead of coming from medial to lateral. It's very fine to do lateral to medial, more comfortable for the patient in the stretcher, easier to position, and it still images that lateral foot, either it be a medial lateral or lateral medial image. Okay, so weight bearing, AP and lateral weight bearing. So horizontal beam for a lateral, you're on this box that's been created. Your patient is standing there. You can see that this foot is back because they're putting all their weight onto this foot, which is what you want for that horizontal beam lateral weight bearing. This here we talked about. So it is a frame, usually plexiglass, that goes over top of your image receptor, so they're not standing directly on that image receptor. 10 degrees posterior to the base of that third MTP joint. So this is, but then this central ray is right in between those feet. Normally they're going to do one foot and then the other foot instead of imaging both feet on one image. Just depends on where you're at. So it demonstrates the bones of the feet to show the longitudinal arches under the full weight of the body. May demonstrate an injury to a structural ligament of the foot, such as a Liz Frank joint injury. So understand that you're doing lateral AP and lateral weight bearing, mostly for a Liz Frank joint injury. Okay. So lateral weight bearing, there's several ways to do it. This is a platform with a slot, and the image receptor slides down into that slot. So you're going to image this way, and then you can turn the patient around, and they're going to be facing the opposite way and image the opposite foot. Okay. So either something like this that's built with that slot, or they're going to stand on an elevated stand, and you're going to use your wall bucky to image that lateral weight-bearing foot. So evaluation criteria, you want bilateral feet demonstrated. Depending on where you're at, it could be both feet on one image, or it's going to be just 1 foot per image, noted as weight-bearing. Phalanges and MTs are not rotated, so you want your phalanges and your metatarsals not to be rotated. Equal concavity on both sides as much as possible. A lot of times you have to adjust their feet so that they are standing in a true AP, flat-footed, as much weight as possible on that foot. And then your evaluation criteria of your lateral. Once again, the entire foot. Make sure you don't clip off the toes. Make sure that your light field comes down underneath the foot to image at least what they're standing on there. The plantar surface of the MTs are superimposed. So metatarsals, the plantar of the metatarsals are superimposed over one another, and then optimal exposure factors. This image here is talking about a composite foot, which you're not going to be able to do on a digital image receptor. They used to do these on film cassettes, so when you had a film, or they would do these, you could do these possible on a cassette. So basically you're double exposing. You're not moving the foot between the exposure. You're keeping the foot in the same position. All you're doing is you're 10 to 15 here for an image. You hold this foot so it doesn't move, doesn't slide. The patient steps forward, and then you're at a 25 degree angle at the posterior aspect of the foot to the calcaneus. And what you end up with is you end up with a composite foot where this is what an AP foot looks like right here, where you're seeing your phalanges and your metatarsals and some of your tarsals. But now you've got this composite foot where you're seeing absolutely everything. Your tarsals, metatarsals, carpals, your calcaneus. It's a really pretty picture, but it's just not possible with a digital image receptor, because when you make the exposure, the image comes across. So you're going to have to image individuals. So it's going to be a picture of the foot, and then you're going to go back and image your calcaneus. So I'll post this, and we'll pick up with calcaneus for our next video, our next lecture.